Hello, everyone. Welcome to our series. Our team is grateful you're here. Of course, seeing you in person would be preferable, but given the ongoing response to managing the SARS-CoV-2 pandemic at Hopkins and our local communities, these virtual platforms have proven to be an efficient means for sharing information and for education and discussion. A couple of updates. Next month, March 8th, I'm excited to announce that Dr. Otis Brawley will be joining us to talk about bladder cancer prevention and control from a national perspective. Dr. Brawley is a Bloomberg Distinguished Professor and serves Johns Hopkins as Director of our Community Outreach for the Kimmel Cancer Center. A trained medical oncologist, Otis has served in leadership roles at Emory and the American Cancer Society. He's a much sought after expert, and I'm sure you will enjoy hearing from him. You can find our updated programming and a new newsletter on the web. Google Greenberg Bladder Cancer Institute. And I wanted again to draw your attention to our evolving group of programs specifically tailored around the experiences of women with bladder cancer, led by Drs. Armin Smith and Jeannie Hoffman-Sensis, and the program team of Pamela Getz, Samantha Rockler, and Stephanie Cooper Greenberg. Again, all of these are up on our site, and if we can help you directly, we are only an email away at bladdercancer@jhmi.edu. It is a pleasure to introduce you to Nirmish Singla, who is joining us today for a conversation about kidney health and bladder cancer. Dr. Nirmish Singla is an assistant professor of urology and oncology in the Brady Urological Institute at Johns Hopkins. He serves as the director of translational research in genitourinary oncology and helps lead the multidisciplinary kidney cancer program at Johns Hopkins. As a urologic oncologist, Dr. Singla is a close collaborator with our Greenberg team, where he works alongside Dr. Hoffman-Sensis in our upper tract program. Dr. Singla attended the University of Michigan Medical School before completing his residency training in urologic surgery at the University of Texas Southwestern Medical Center in Dallas. He then completed a specialized clinical fellowship in urologic oncology at Memorial Sloan Kettering Cancer Center in New York through the Society of Urologic Oncology before joining our faculty. More than their incredible portfolio of discovery, Nirmish represents the very best of our institute's focus and commitment to patients and families. I'm grateful for his service to our patients, families, and larger community. Dr. Singla, welcome, and thank you for joining us today. Nirmish has agreed to speak for about 30 minutes or so, and then we'll jump to a larger group discussion. I would ask for folks to bring their questions into the chat, and after the conversation, we'll have ample time for group discussion.
Excellent. Well, I really appreciate that kind introduction, Dr. McConkey. Let me just go ahead and share my screen. Hopefully this will work. Okay, fantastic. Good afternoon, everybody. And again, it is truly my honor and privilege to be able to speak at today's GBCI Grand Round session. Today, I wanted to highlight a topic that I think deserves considerable discussion related to kidney health as it pertains to patients with urothelial carcinoma. I think in the original flyer, it said bladder cancer, but I did want to highlight some particular nuances as it pertains also to a lesser common entity referred to as upper tract urothelial carcinoma as well. And so I wanted to just first discuss things for a little bit from my perspective, and then have an opportunity to allow for this to be an interactive forum so that if anyone has any questions pertaining to kidney health in urothelial carcinoma, and there will be ample opportunity to discuss thereafter. And just to begin, I have no relevant disclosures. Okay, so the goal of today's talk would be largely to first start off by discussing what kidney health truly is. So this is a bit of a more fundamental introduction, but I think it would help set the stage for what it is that we refer to when we talk about kidney health. And then I wanted to talk a little bit about the nuanced relevance of kidney health, first as it pertains to bladder cancer and the treatments for bladder cancer, and then talk about its relationship to UTUC, or upper tract urothelial carcinoma. So first, what is kidney health? So again, this is probably fairly fundamental, but just to kind of go from the ground up. The kidneys, as you know, are two about fist-sized organs in the body that undertake a number of vital functions. These include things such as eliminating waste products and drugs and toxins into the urine, regulating electrolyte concentrations, fluid balance, and blood pressure for the body, maintaining an acid-base homeostasis, and also producing important hormones that are relevant to both blood production as well as bone health. Now, when it comes to kidney health, we are essentially, for the purposes of this talk, referring to kidney function or renal function. Now, this is typically measured by what we refer to as estimated glomerular filtration rate, which is a calculation that's based on essentially blood work. Serum creatinine is one of the most important surrogates for one's overall kidney function or kidney health. And furthermore, an assessment of the urine can also play an important role, as the presence of protein in the urine can sometimes also signify potential dysfunction in the kidneys. Now, I do want to also make the distinction between the role of various specialists when it comes to kidneys. As a urologist, my primary role tends to be largely surgical in nature when it comes to doing kidney surgeries. However, we also tend to interface very closely with nephrologists, who are internal medicine trained medical specialists who deal with the medical aspects of kidney health. And so in large part, they would be the ones to monitor kidney function over time, and also take into consideration aspects related to prevention of chronic kidney disease, and looking at aspects of medications and various interactions they may have that could have some influence on kidney function. And so having that close interplay between different team members and engagement with a nephrologist is absolutely critical. And when we talk about overall kidney health, worsening of renal function is what we refer to as CKD, or chronic kidney disease. And this is entirely measured by the eGFR, or again, the glomerular filtration rate. And in general, when we find that the eGFR falls below 60, that's when we start to get more concerned about stage 3 chronic kidney disease. And as we start to get closer and closer to 15 or less, that's when we start to worry about end-stage renal disease, and considerations like dialysis become more pertinent at this stage. And so just to give some basic fundamental framework for our discussion today, there are a number of predisposing risk factors that have been identified for the development of CKD. And these include things like underlying medical conditions such as diabetes, hypertension, cardiovascular disease, and obesity, environmental exposures like tobacco use, even inherent genetics that may pertain to, for example, African-American race, or having a family history of CKD, congenital and acquired structural abnormalities, recurrent urinary tract infections, specifically pyelonephritis, which can sometimes lead to scarring in the long term, chronic obstruction, things related to, for example, kidney stones or other structural reasons for why there may be some obstruction that has developed, and also an increased risk with advanced age. Now, when it comes to symptoms of CKD, these generally tend to be very non-specific. So there isn't necessarily a specific symptom per se that may suggest the presence of CKD. However, patients who do suffer from CKD may exhibit some constellation of symptoms that could include things like nausea and vomiting, loss of appetite, fatigue, weakness, changes in urine volume, which in some cases may involve decreased urine output more often, but in some cases, even unconcentrated elevation of urine volumes can also signify a potential issue related to the kidneys. Altered mental status or confusion, muscle cramps from electrolyte abnormalities, swelling that can develop from fluid retention, dry or itchy skin, and then other manifestations such as higher blood pressure, shortness of breath, chest pain, or palpitations. Now, the reason why it's very important to manage CKD is because when left unchecked, there can sometimes be very serious sequelae related to CKD. And these include things like, again, exacerbation of hypertension from fluid retention, electrolyte imbalances that could potentially lead to cardiovascular dysfunction due to the importance of the kidneys in bone health and blood production as well. There can sometimes be an increased risk of bone fractures or anemia, decreased sex drive and fertility-related issues, altered mental status, and potentially even seizures, compromise of the immune system, even pregnancy complications for those who are currently or hoping to get pregnant. And then again, as the kidney function continues to deteriorate, there is this concern for development of end-stage renal disease and potential dependence on dialysis. It has also been found to be an independent predictor in and of itself of accelerated mortality to have chronic kidney disease. And for these reasons, we do pay serious attention to one's kidney function. And so for these reasons, we do want to look and see if there are ways in which we can help preserve kidney health overall, and specifically ways in which we can maybe prevent deterioration of kidney function, both in patients who have normal kidney health at baseline, as well as those who may have some degree of compromise. And so some ways that are important to keep in mind include medications and their dosing, the types of medications patients may be on, the way that they are cleared from the body, as well as interactions with one another. Maintaining a healthy lifestyle. So from the standpoint of things like blood pressure control, blood glucose control, maintaining an overall healthy weight, avoidance of risk factors like tobacco and other exposures, and then maintaining an adequate degree of hydration. And then again, early consultation with a nephrologist can absolutely be paramount for patients who either may have some early signs or lab values that may suggest potential development of renal compromise, or in patients who may have needed to have surgery that either has amounted to removal of a kidney or may result in some iatrogenic compromise to the kidney function. And now also as being a kidney surgeon myself who almost routinely removes kidneys from the body, I do want to also answer a question that I often will get in the clinic, which is, is it possible to live but then also live a healthy, normal life with just one kidney? And the answer to that is that it is, in fact, indeed very possible to live a normal, healthy life with just one kidney. But the caveat is that it is important to pay attention to these factors on the slide and ways in which we can try to prevent renal deterioration, and making sure that, if needed, early consultation with a nephrologist and monitoring of the kidney function are implemented in those cases to help optimize outcomes in the long term. Okay, so now that you have sort of a nephrology 101 fundamental basic about kidney health, I wanted to transition to sort of the meat and bones of this talk, which is the relationship of kidney health and urothelial cancers. And again, I wanted to break up this talk by focusing primarily on bladder cancer, but then having an opportunity to also discuss its relationship to UTUC. So with respect to bladder cancer and kidney health, these are absolutely intimately related for a number of reasons. The first consideration when approaching patients who have bladder cancer is to get a sense of what the baseline kidney health is. And the reason for that is multifold. First is to consider the types of treatments that patients may be eligible for, since that is largely predicated on what the baseline kidney function is. In particular, one thing we very often think about is eligibility for certain systemic treatments because of the potential toxicities that some of our treatments will have on the kidneys, and I'll go into this in more detail momentarily. For patients who are requiring a definitive or extirpative surgery, i.e. a cystectomy to remove the bladder, the type of urinary diversion that can be offered to a patient may also be influenced by what the baseline kidney function looks like. And then also CKD can be a surrogate assessment of one's overall general health. And because of that, one's operative candidacy may be influenced by whether or not there is CKD or other related comorbidities at baseline. The other aspect to make mention of here also is that ideally, when it comes to staging patients who are diagnosed with bladder cancer or urothelial cancers in general, we rely heavily on iodinated IV contrast enhanced cross-sectional imaging. And so the unfortunate aspect of IV contrast is that it does have potential deleterious effects on the kidney, or at the very least, it's cleared from the kidney. And so for those who have a compromised baseline kidney function, that may limit our ability to perform such imaging for adequate staging imaging. But in addition to baseline kidney health, it's also pertinent to maintain kidney health both throughout the treatment course and then in the long run once treatment is complete. And the reason for this is also pertinent to the types of therapies that we use for bladder cancer, because of the systemic therapies, which now more and more will incorporate either platinum-based nephrotoxic chemotherapies or the use of immunotherapies. And again, I'll go into this in a bit more detail momentarily. And then also some of the sequelae from having a urinary diversion, which is essentially a segment of bowel that then becomes the conduit or the pouch by which urine can be eliminated from the body. We also continue to surveil patients long-term using cross-sectional imaging, which may require the use of iodinated contrast. And then patients with bladder cancer also have the potential for recurrence in the upper urinary tracts or developing UTUC. And again, I have a segment of this talk dedicated to UTUC specifically, but some of those treatments may also impact kidney function overall as well. So the first aspect related to bladder cancer treatment and eligibility for treatment is predicated on the use of chemotherapy. Now, this, I should mention, this is specific to intravenous chemotherapy, so systemic chemotherapies, and not so much for patients who maybe require topical chemotherapy installations into the bladder, which are not quite systemically absorbed in the same manner as IV chemotherapy would expose the kidneys. But essentially for patients who either have non-metastatic muscle invasive bladder cancer, who may benefit from neoadjuvant or preoperative strategies with chemotherapy, or patients with metastatic bladder cancer who may benefit from induction chemotherapies. The current gold standard approach is to use a cisplatin or platinum-containing regimen. Now, the problem with cisplatin is that, unfortunately, it tends to be a relatively harsher type of a chemotherapy, and in large part, some of the toxicities associated with cisplatin are due to the kidneys. So baseline kidney function would determine whether or not a patient may be eligible to receive cisplatin, but then also for patients who are eligible to receive cisplatin, there may be some concerns as well related to how their kidneys may fare during and beyond the completion of treatment. Now, there has been an immense body of literature that has emerged, particularly from the nephrology groups, that have looked at understanding the underlying mechanisms of nephrotoxicity amounting from cisplatin-based chemotherapy. And there have actually been a number of different mechanisms proposed and shown through a variety of basic science models. And these include a combination of perhaps direct tubular injury, so direct injury of the agent to the nephron or the functional unit of the kidney, vascular injury and ischemic related complications from the agent, apoptosis or essentially direct cytotoxicity to the cells, oxidative stress and the generation of free oxygen radicals. And one thing that has garnered considerable contemporary interest is whether there is also an inflammatory role that chemotherapy may play in terms of potentiating renal damage. Another emerging type of systemic therapy that is starting to gain more and more traction, especially for urothelial cancers, is something called immune checkpoint inhibitors. And these are starting to play more of a role either in isolation or in combination with other agents. And in general, the benefit of these is that compared to, for example, cisplatin-based chemotherapy, immune checkpoint inhibitors tend not to carry the same degree of renal toxicities. However, there have been some manifestations of renal injury that have been found to amount from the use of these types of immunotherapies. In general, the main form of renal dysfunction that has been shown to be directly attributable to immunotherapies is something called acute interstitial nephritis, or essentially an inflammatory induced renal compromise. And that may be seen in about anywhere from 2 to 5% of patients who are on immunotherapies. However, there are also other mechanisms that may play a more minor role that may amount to renal dysfunction in patients who are on these therapies. And these include things like ATN, or acute tubular necrosis, thrombotic microangiopathies, and multiple glomerular diseases. Now, even though these are the types of toxicities that are thought to be directly attributable to immunotherapies, the overall quoted rate of patients who may have some form of renal dysfunction while on immunotherapy may be even as high as, say, 15 to 17%. And these may be, again, more multifactorial and could be related to other causes as well. Furthermore, the use of these immunotherapies may compound renal failure when there are other types of therapies being utilized or other medications that may pose risk factors for developing renal dysfunction. And generally, if a patient were to develop some form of an immunotoxicity from these types of therapies, generally the first step would be to discontinue the offending agent, and then secondarily, if needed, consider means of immunosuppression to basically scale back on the body's innate immune response to these agents that may be causing the nephritis. So things like steroids or even stronger immunosuppressant agents can be used as well. And I wanted to highlight this complex interplay between the immune system and toxicities with respect to the use of these types of chemotherapy agents, because this actually is an active area of engagement with some of our own investigators here at Johns Hopkins. And I highlight here some monumental work done by one of our transplant nephrologists, who is also a basic scientist, Dr. Hamid Rab, who over the course of the last 15 to 20 years has made quite a few discoveries in the world of nephrology and specifically cisplatin-based toxicities. And so one thing I wanted to highlight here is some of his recent work looking at double negative T cells and their ability to perhaps protect against platinum-induced renal dysfunction. These specific types of T cells are part of the immune system, but they are importantly an immunosuppressive type of modulatory group of cells. And so the thought is that there may be some form of a complex interplay between immune-mediated mechanisms and platinum-induced nephrotoxicities that we're finding that there could be a protective role when the immune system is able to be suppressed within the kidney. And that essentially lends more evidence that cisplatin-based toxicity to the kidney may be, at least in part, due to these inflammatory mechanisms. This is absolutely an area of ongoing interest in the nephrology community. This also begs the question of whether there may be opportunities for further discovery of biomarkers to help predict renal dysfunction in patients who may require cisplatin-based chemotherapy. And indeed, through partnerships between our group and others, such as Dr. Rob, I think that this absolutely highlights a very important role that interdisciplinary collaboration can play in terms of making more discoveries in this realm. Shifting gears here, there's also some important aspects related to renal function as it pertains to surgical management of bladder cancer. So for those who do have typically either refractory high-risk non-muscle invasive bladder cancer, or those who have—
No, I get it.
Sorry. Or those who have muscle invasive disease and require surgical extirpation, there needs to be a way in which the urine can exit from the body. And so in these patients, we often will refashion a segment of bowel and create what's called a urinary diversion, of which there are several types. Now, the caveat of urinary diversion is that it does involve the contact between a viable segment of bowel and urine as well. What this means is that there are implications with respect to reabsorption of certain parts of the urine or secretion of other electrolytes into the urine that can sometimes alter the normal acid-base balance within the body or amount to metabolic derangements. So there are a few different types of urinary diversions. These include an ileal conduit, which is the simplest form and involves the least amount of bowel. But then there are also other continent forms of urinary diversions as well. And the types of electrolyte abnormalities that can sometimes be seen with urinary diversions tend to be more pronounced for patients who have these continent diversions by virtue of having a larger surface area of contact between urine and bowel, but then also a longer duration of contact as well. The issues that also sometimes arise is because of the inherent metabolic abnormalities that may arise from having these types of diversions. Patients may represent with issues related to dehydration or failure to thrive, and unfortunately, this can sometimes further compound acute renal injuries. And so because of these reasons, we actually do utilize baseline renal function as a means to stratify which patients may be appropriate for receipt of some of these types of diversions. And in particular, because of the more pronounced risk of having electrolyte or metabolic derangements with the continent diversions, baseline renal dysfunction is often a contraindication to continent diversions when we're counseling patients in the office. Now, I wanted to highlight this study. It was actually just published last month by one of my close colleagues on the West Coast, because I thought this was actually a very interesting sort of analysis of renal function in patients who are undergoing radical cystectomy. And essentially within the study, the investigators assessed factors associated with developing advanced chronic kidney disease, defined as essentially an eGFR of less than 30 or stage 4 and 5 CKD, after undergoing a cystectomy across more than 3,000 patients captured within the Veterans Affairs database, spanning across about 15 years of data. What was remarkable is that, well, over the course of 5 years that they assessed patients postoperatively, there was an overall decline in kidney function in patients who had received a cystectomy and ileal conduit or neobladder. And in particular, the decline was most pronounced within the first 12 months of undergoing surgery. Now, the aspect that is more concerning is that nearly 1/3 of patients, or about 30% of patients, actually progressed to CKD stage 4 or 5 within those first 12 months. And now this may be certainly multifactorial, as it may pertain also to other underlying health conditions or exposures that may predispose patients to forming bladder cancer that may also compound renal function. And so the investigators also then performed a multivariable analysis to assess for any factors that may be associated with development of advanced CKD post-op in these patients. And they did identify that factors such as advanced age, preoperative hydronephrosis or obstruction of the kidneys, use of adjuvant chemotherapy, higher baseline comorbidity index, lower baseline kidney function, all amounted to increased risk of developing CKD. Interestingly, there was no difference based on whether a patient had received neobladder or an ileal conduit, although some may argue that there could be some selection bias in selecting patients to receive a neobladder based on baseline CKD. However, an important point that did emerge from their analysis is when looking at mortality risk, lower baseline kidney function was significantly associated with a higher risk of death in patients undergoing cystectomy. And as a result, from the standpoint of patient counseling, as well as understanding risk stratification for patients undergoing surgery, this should be a factor that is included within the counseling process. Switching gears here, I did want to talk a little bit also about a less common form of urothelial cancer called upper tract urothelial carcinoma. For those of you who attended one of our earlier GBCI Grand Round sessions, you may have received a little bit of background about this entity, so I won't go into too much detail, but in general, as far as urothelial carcinoma, it can arise anywhere along the lining of the urinary tract from the kidneys down the ureters all the way to the bladder. And whereas bladder cancer accounts for anywhere from 90 to 95% of all urothelial cancers, about 5 to 10% may be of this flavor called UTUC. And this is actually particularly nuanced as it relates to kidney health for a few reasons. Paralleling the earlier slide on bladder cancer, we first have to look at baseline kidney health because that does affect eligibility for certain treatments. We talked about the use of certain systemic therapies, which in large part are mirrored in UTUC off of what's used in the bladder cancer space. But then also there are important unique treatment strategies from a surgical standpoint for patients with UTUC, as the gold standard approach typically entails the removal of a renal unit or a nephroureterectomy. And there are emerging interests in terms of renal sparing approaches to help maximize kidney function among these patients. Furthermore, imaging, cross-sectional iodinated contrast-based imaging also plays an important role in staging these patients. But then again, aside from the baseline aspects related to kidney health, for patients who are receiving treatment for UTUC, maintenance of kidney health remains paramount as well, again, due to the toxicities from the use of similar systemic therapies as is used in bladder cancer, but then also the fact that oftentimes if you do have to remove a kidney from a patient, how do we continue to maintain an appropriate health of the overall kidney state? And so for that, it absolutely becomes even more paramount to engage with early consultation with a nephrology specialist. Now, with respect to UTUC, I'm just going to talk a little bit about the role for systemic therapies. As we know, for bladder cancer, there is level 1 evidence that has supported the use of neoadjuvant or pre-surgical cisplatin-based chemotherapy regimens prior to surgery in patients who have non-metastatic muscle-invasive bladder cancer. In the space of UTUC, we lack the same level of evidence. However, there is absolutely a role for the use of systemic therapies, and the timing and the role have continued to be in flux and continue to evolve today. Unfortunately, with UTUC, patients often at baseline tend to, on the average, be a bit older, a bit sicker, and oftentimes have multiple factors that may predispose them to having baseline CKD. In fact, if you were to sort of look across a number of series, anywhere from 37 to 58% of patients with UTUC may be eligible to receive chemotherapy even prior to undergoing any treatment of their UTUC. Unfortunately, that renders a substantial proportion of patients, nearly half of patients, ineligible even before treating them. As a result, the actuarial utilization of platinum-based chemotherapy is largely limited because of the exclusionary factors related to their baseline health. And so when we treat patients with UTUC, it becomes a fine balance because on the one hand, we perceive oncologic benefit. So treatment of the cancer may benefit from use of the chemotherapy agents. But then on the other hand, there's also the concern about increased mortality risk related to kidney failure. And so trying to traverse that balance and finding the appropriate balance between risking mortality from cancer versus risking mortality from end-stage renal disease becomes a very nuanced discussion and one that often can challenge the discussions that we have with patients in this space. The other aspect unique to this disease is that, again, if the definitive gold standard approach for non-metastatic patients is to remove a kidney, that often will further compromise the kidney function. And so for patients who did not receive chemotherapy up front, doing a surgery may further limit the ability to give chemotherapy adjuvantly or postoperatively. And series quote, only 15% or so of patients may remain eligible. And so this had actually been an active area of interest of mine back when I was in residency, and between some of the studies that we looked at the time, as well as other contemporary groups, there had been quite a few studies that had emerged with interest in understanding predictors of outcomes in renal function after undergoing extirpative surgery for this type of disease. And indeed, there has been ongoing efforts to sort of push the envelope as far as surgical approaches that may be able to spare the kidneys in as much as we can. And so some of the work that we looked at tried to assess whether doing a radical nephroureterectomy or removing the kidney and ureter versus just removing a segment of ureter and sparing the kidney may potentially impact kidney function, and what other factors are there associated with worsening function after undergoing extirpative surgery. Some of the findings we reported on included that adjuvant chemotherapy did appear to be the most significant predictor of new or worsening chronic kidney disease after undergoing surgery. And furthermore, patients who have had some hydronephrosis, or essentially obstruction of the side that's affected at baseline, are those who are actually more likely to experience less of a decline in their kidney function. And this makes sense logically, since the concept here is that these patients have likely been obstructed for some degree of time and has allowed for their other kidney to accommodate some of the kidney function to some degree before that kidney is removed. This also actually, for better or for worse, does work in these patients' favor, because we've also noted that patients who demonstrate hydronephrosis in UTUC often have characteristics associated with worse prognostic outcomes. And so these are the patients who are more likely to derive benefit from the use of chemotherapy. And so if we are able to less likely impact their kidney function by removing the kidney, at the very least, we can hope that their kidney function will remain relatively well preserved despite a surgical intervention. We also did a follow-up systematic review shortly thereafter, systematic review and meta-analysis, assessing both oncologic and renal functional outcomes based on the surgical approach. In other words, sparing the kidney versus removing the kidney and ureter. Not surprisingly, it was in fact shown in the meta-analysis that patients who did have removal of the kidney compared to those who just had a segmental ureterectomy or just removal of the affected segment of ureter, they did have worse renal functional outcomes. Now, I did also want to highlight that, again, the role for chemotherapy is one that continues to evolve in UTUC, and given the relative rarity of this disease, it is actually rather challenging to conduct good evidence, sort of well-controlled prospective trials in the space. That being said, a couple of years ago, there were two important clinical trials that were published. First was one that was published in the adjuvant or postoperative state. This is something called the POUT trial, which is a phase 3 randomized controlled trial. In this trial, patients would undergo nephroureterectomy and receive either cisplatin, or for those who are ineligible based on their kidney function, carboplatin, versus surveillance strategy alone for locally advanced UTUC after surgery. And as it turned out, from a cancer control perspective, patients who received chemotherapy exhibited an approximately 25% absolute benefit with respect to recurrence and mortality rates, attesting to the benefit of chemotherapy in general for these patients. Now, there may be some who would say that, with this trial, based on what I showed earlier with respect to eligibility for chemotherapy, especially post-nephroureterectomy, there's a substantial handful of patients who may not even be eligible for this type of an approach. And that served as the underlying rationale to conduct a trial that was actually led, it was a multi-institutional trial, but led here by Dr. Hoffman Sensitz herself, termed the ECOG Akron 8141 trial. This was a phase 2 single-arm trial that included the use of neoadjuvant cisplatin-based approaches or gemcitabine carboplatin for the few patients that were ineligible based on their kidney function for high-grade UTUC prior to undergoing nephroureterectomy. This was actually noteworthy for certainly a few reasons, but looking at what's called the pathologic complete response rate, or the essentially the eradication of disease seen in the final specimen after it was removed, about 14% of patients actually had no residual disease after the use of chemotherapy. Furthermore, they also had noted that over 60% of patients had been found to have non-muscle invasive disease on their final specimen, either from presumably downstaging from chemotherapy, or perhaps in a subset of patients, even just inherently lower stage disease to begin with. And so this has largely become our institutional preference for patients who do present with higher risk UTUC, in that we often try to offer them chemotherapy in a neoadjuvant setting whenever they're eligible to receive it. I won't belabor some of the ongoing work too much or get into the weeds too heavily here, but I did want to highlight that there are indeed a number of ongoing active research efforts here at Johns Hopkins to better understand the role for kidney health in UTUC. Again, as I mentioned earlier, in large part, we are trying to discover ways in which we can better spare kidneys while also balancing that risk of cancer control. And so just to highlight some of the ongoing efforts, there are multi-institutional collaborations that we are involved with, one of which is being run by Dr. Rahman at Penn State University, looking at endoscopic management or ureteroscopic management alone for patients who present with UTUC to better understand if this is a technique that could potentially be applied to high-risk patients while minimizing the risk of cancer spread. This is a technique that generally has been reserved for patients with lower grade disease, and yet we don't fully understand whether it's effective or not for higher grade disease. We also tend to reserve it for patients who are not great operative candidates. Other studies worth highlighting, there was a trial that Johns Hopkins was a part of that led to the FDA approval for a mitomycin-containing reverse thermogel, currently marketed as Gelmido, particularly for patients with low-grade UTUC that may be endoscopically unresectable. The idea behind using this agent is hopefully to decrease the chance of recurrence in the future, but also offer an opportunity to spare the kidney. We also have an upcoming trial that is currently undergoing regulatory review, and we hope to have off the ground, if all goes smoothly, within the next month or two. It is currently open at other sites, and we're hoping to open our site here at Johns Hopkins, called the Enlighted trial. This is a phase 3 trial using a novel laser technology, essentially referred to as a vascular targeted photodynamic approach, in which we likewise hope to be able to better manage patients with low-grade UTUC more effectively, and again be able to offer them kidney-sparing approaches to their care. And then there's also another trial that Dr. Hoffman-Sensitz has been working on, referred to as the renal retention trial, for those who are either medically inoperable or who outright refuse undergoing an nephroureterectomy as another means of retaining the kidney or kidneys. There are other ongoing efforts as well in which we are involved related to UTUC and kidney health. There is another trial that, again, Dr. Hoffman-Sensitz can attest to. This is similar in scope to the prior trial that I mentioned before. This is like the ECOG-ACRIN 8141 trial. This is the ECOG-ACRIN 8192 trial that involves neoadjuvant use of not just cisplatin-containing chemotherapy, but also in combination with an immune checkpoint inhibitor called durvalumab. And then there are other collaborative efforts with our colleagues at other institutions trying to better predict the post-operative decline in kidney function after undergoing nephroureterectomy. And we feel that this is absolutely pertinent to patient counseling when we are considering surgery for patients with UTUC. And so just to sort of wrap things up, and again, I do want to leave adequate time for questions, just some concluding remarks. You know, as highlighted here, absolutely maintaining kidney health is crucial to optimizing outcomes and survival in general, but then especially within the realm of urothelial carcinoma, patients' kidney healths are absolutely very intimately tied with the management of both bladder cancer and UTUC. And the reasons for this is because A, baseline renal function influences treatment options that are available to patients, but then B, the treatments that we offer are also tightly impact kidney function. And specific to each disease state, both bladder cancer and UTUC, these carry inherent nuances with respect to kidney health that I outlined herein. This is absolutely an active area of academic interest to us with practical applications clinically, and so we are engaging in ongoing work both through collaborations internally and collaborations externally towards maximizing kidney function in patients affected by urothelial carcinoma. And I think hopefully this talk has highlighted the importance of engaging a multidisciplinary, personalized approach to each patient, specifically with easy access to nephrology consultation, given the paramount role that they play for patients who have urothelial carcinoma in the long term. And I'll also just utilize this opportunity to put in another plug for a recently implemented UTUC multidisciplinary clinic that was officially launched last year as a way to help streamline the ability to allow patients access to specialists, both in nephrology and in other fields, who may have this more complicated, intricate form of a disease that would warrant care from not just a urologist and not just a medical oncologist, but perhaps other specialists as well. So on that, this is my last slide. I do want to thank you again for the opportunity to present at today's GBCI Grand Round session, and of course I'd be more than happy to answer any questions that the audience may have.
Nirmish, maybe if you would, you could stop sharing your screen.
Absolutely.
Great. So I'm going to start with a question derived in the chat. And the question is bladder cancer or kidney stones a risk factor for CKD?
It's a very good question. I think the nuances related to bladder cancer, I think that we discussed herein, I think are important to consider, because absolutely the treatment options that exist for bladder cancer can be directly related to the development of CKD. The bladder cancer in and of itself, the thing we tend to worry the most about when it comes to kidney function would be that sometimes bladder cancer can result in obstruction of a or both kidneys, either from the bladder itself or even potentially from enlarged lymph nodes or other sites of metastasis. And so in those scenarios, we do tend to have worry about kidney cancer, about chronic kidney disease directly related to the bladder cancer itself. With respect to kidney stones, that absolutely is something that is, again, tightly related with kidney health. I didn't devote this talk towards kidney stones specifically because it does, I think, warrant it's enough of a topic that I think one could do an independent talk on that. But with respect to kidney stones, so the issues that may relate to that in kidney function would include obstruction of the urinary tract that can sometimes cause hydronephrosis or worsening kidney function related to that, as well as sometimes the repeated treatments that patients may require for kidney stones, repeated manipulation of the urinary tract, either through ureteroscopy or percutaneous nephrolithotomy, that in and of itself can also sometimes cause ureteral scarring over time if they're frequent stone formers.
Thanks, Nirmish. So I'm going to go to the question and answer now. What nephron-sparing surgical approaches are available for patients with high-grade uterine tumors, upper 1/3, mid 1/3, distal 1/3?
It's an excellent question, at the moment, so when we're thinking about high-grade tumors, surgical management, the gold standard would be currently extirpative surgery. So extirpative, what does that actually mean? It means removal of the involved segment. The gold standard typically would be, certainly for renal pelvis tumors or tumors within the proximal ureter, generally a nephroureterectomy. Yeah. Now, there has been a contemporary interest in trying to see if there's the ability to remove the segment of ureter and reconstruct the urinary tract in a way that we can still obtain comparable oncologic outcomes. For patients who have a distal ureteral tumor, doing something called a distal ureterectomy, or removing the last part of the ureter and then reimplanting the more proximal portion of the ureter, the upper part of the ureter, back into the bladder, is an acceptable approach and has actually been shown to carry similar oncologic outcomes even in the setting of high-grade disease. The challenges that we start to face from a technical standpoint arise when we start to try this approach for patients who have tumors that are higher up. So even in the mid-ureter, for example, we sometimes have to become more creative if we're going to try and make an aggressive approach at saving the kidney. Sometimes there are ways to make something called a Boari flap, or essentially utilizing a flap of the bladder to help bridge the gap in the ureter that would result. Sometimes we have to do something called the psoas hitch to basically mobilize the bladder and tack it up on the psoas muscle to help it reach. There are also techniques such as a downward nephropexy, so mobilizing the kidney to make it come down a little bit to help reach the bladder. There are other techniques as well that may be subject to complications, things that involve interposition, sometimes even using the bowel segment. But we, for urothelial cancers, often take more pause when we try to apply these types of approaches. The practice of doing something called the segmental ureterectomy, where you just remove a segment of ureter and then conjoin the ureters back together for benign strictures is not as unreasonable, but for cancer approaches may be less desirable from a cancer control perspective. So when we start to see tumors higher up and we're looking at definitive surgery, a nephroureterectomy usually tends to be preferred. And then the other aspect would be, again, we're looking at endoscopic approaches. We're trying to explore whether high-grade disease can be as effectively managed through ureteroscopy and laser ablation or other techniques, ancillary techniques. And that is an ongoing question right now.
Thanks, Nirmish. How long does it take for ureteral obstruction to cause permanent decrease in renal function?
That's an excellent question as well. So we often, so there have been actually a number of studies that have, on a basic science level, that have looked at the time that it takes for obstruction. These are largely, I think the main interest was related to kidney stone studies, but essentially to see if you were to occlude the ureter, what would be the impact in terms of a kidney's function. And so even immediately, there have been some changes that have been seen, even as soon as an hour after clamping, for example. But relief of the obstruction in those cases may be amounting to more reversible changes, particularly in patients who have no other risk factors for developing chronic renal disease. The longer it remains obstructed, certainly the longer we start to worry. There are patients who present with kidney stones to the emergency room that we are often comfortable with simply a trial of passage, which can last sometimes even a few weeks without going in and having to operate right away. However, when we often tend to see that the stone hasn't passed after usually a few weeks, then we start to really think that we should go in and definitively treat it because of the potential for irreversible damage to the kidney. The reversible damage sometimes can be present initially after the inciting event, but again, that often can be rectified sooner rather than later.
Thank you. Since creatinine levels are critical to care and treatment options, is there recent research on effective ways to help manage those levels, or other than proper hydration?
So for the creatinine levels, so the issues largely amount to understanding what the inciting cause is for increasing the creatinine level. So if it is an issue, so there's essentially three major categories of kidney dysfunction. There's a pre-renal etiology, so that usually means oftentimes a lack of hydration or perfusion to the kidney. Then there's an intrinsic cause to the kidney itself. These are often related to things like medication effects that can sometimes impact the kidney directly, or there may be even some other anomalies inherent to the nephron or the functional component of the kidney. And then there's the post-renal or the obstructive causes. And so if we're dealing with the pre-renal causes, then usually hydration would be the mainstay. If we're dealing with some of the intrinsic causes, then removal of the offending agent and trying to understand the specific etiology would be ways to address the creatinine issue. And then if it's an obstructive issue, then relieving the obstruction or bypassing the obstruction, either with a stent or a nephrostomy tube, would be ways that the kidney function can be addressed in that manner.
Thank you. What's the significance of suspicious urine cytology from the upper tract for over 2 years that changes from suspicious to atypical to negative?
So cytology, it's honestly, it's a bit of a moving target, and specifically for the upper urinary tract, we do tend to utilize it more from its aspect of specificity as opposed to sensitivity. When we do see, so what I would say is when we do see that there is definitive high-grade urothelial carcinoma in a cytology specimen, then often that is indicative that there is some form of a high-grade urothelial carcinoma somewhere along the urinary tract. When we see, I'll jump to sort of the atypical or sometimes the non-specific reads that we get on cytology. We often don't necessarily make too much of them because it can be compounded by other aspects such as infections or inflammation that can impact what we see under the microscope. And so like an atypical cytology is usually not one that tends to raise a lot of concern. Suspicious is kind of that middle ground that becomes a little bit harder to understand if it truly is significant or not. When we see that there is some significance, it's certainly something that we pay attention to and try to monitor more closely. But serial cytologies in and of themselves, because of the low sensitivity of them, especially for the upper tract, we don't often tend to place a lot of value on them when they do come back negative or equivocal. And oftentimes, if there is any suspicion, a direct assessment visually with a ureteroscopy would be the way to more definitively assess that.
Just to elaborate on that, we're working with colleagues at Hopkins and also here at Fox Chase and other places to try to develop what we call a liquid biopsy in urine, which might complement cytology to help us make more accurate diagnoses. That's a way of, liquid biopsy is a way of measuring tumor DNA, usually through mutations by sequencing DNA from the urine. So stay tuned on that. So how can patients avoid or lessen the incidence of UTIs, or can they? Is there anything one can do to avoid UTIs?
So, UTIs, it's a pretty complex topic because they tend often to be very multifactorial. There's a number of different types of UTI or flavors of UTIs, if you will. And consequently, there's a number of reasons why patients develop UTIs. And some of them can be more structurally related to the urinary tract. Sometimes there can be something more related to the activities one is doing that may end up amounting to an increased risk of UTIs. And so when it comes to urinary tract infections, there are things that people have looked at to better understand, is it an issue with respect to emptying the bladder properly? And if that's the case, then maybe addressing outlet obstruction would be the way to address that problem. Or, is it something that people have looked at, for example, the pH balance in the urine? Is that something inherent to the development of UTIs? The use of cranberry juice has also been explored. And so it is a little bit of a nuanced question, but indeed there are ways to potentially minimize UTIs, but it largely depends on what the underlying cause or reason for the UTIs are upfront.
Thank you. So Ann Hoffman wonders, the most common treatment for non-muscle invasive bladder cancer is BCG intravesically. Any connection between BCG and CKD?
Yeah, so fortunately, with intravesical therapies in general, the idea is that they're hopefully just a topical therapy with minimum systemic absorption. And so in general, when applied in the strictest form, and if there is no absorption, then the presiding thought is that there should be no direct connection with the kidneys, being that it's simply located in the lower urinary tract. Now, the mechanism of BCG is such that it does amount to a local inflammatory response within the bladder. And so whether or not that translates to any sort of inflammatory response in the kidneys, I don't think has actually been specifically studied, but I would suspect that unlike the case of, for example, immunotherapies that are administered intravenously, there would be a less likelihood for a direct impact on the kidney function. Now, that being said, I will also put the caveat in that patients who receive BCG sometimes are at risk of developing systemic side effects from absorption of the agent. And so one of the rare complications, for example, from BCG is something called BCG sepsis or other forms of BCGosis, where there could be some dissemination of the essentially the tuberculin that's contained within the BCG. And so whether that may secondarily impact kidney function, I think is certainly a possibility, but very much a rare complication for topical therapies.
Thank you. So when a person has undergone removal of the bladder and has a conduit, do UTIs happen more frequently because of the new plumbing, and why and how?
Yeah, so when it comes to patients who require urinary diversion, like I said, a segment of bowel ends up becoming the route of urination, urine elimination. And so generally these become colonized, especially for patients who have a continent catheterizable stoma, or importantly for patients who have ileal conduits, they're going to be colonized with bacteria. So every time you get a urinalysis or even a culture from the urine from someone who has an ileal conduit, I would expect there to be a UTI, if you will, because of that asymptomatic colonization that essentially occurs. That being said, there are also forms of pathogenic UTIs, and these are the types that do require. So I'll mention that for the asymptomatic bacteriuria that's often inherent, we don't tend to worry so much about necessarily treating them. But for patients who do generate pathogenic UTIs or symptomatic UTIs, and especially for those who may develop symptoms of pyelonephritis, because the urine has the ability to sometimes go back up in the reverse direction towards the kidney, those are situations in which treatment is warranted to help minimize potential sequelae from the infection itself.
Thank you. Do kidney transplants enter the work you do? If so, under what conditions, and are those with UTUC candidates?
Yeah, so good question. Kidney transplantation has largely become under the umbrella of our general surgery trained transplant surgeons. Now, that's not necessarily the case everywhere across the country. So there are still urologists who partake in kidney transplantation, more so in the past than today. In my personal practice, I don't tend to do kidney transplants. However, I do work very closely with our transplant surgeons and the transplant team. And they actually have established guidelines through their society in terms of when it's appropriate to offer a kidney transplant to patients who have had a history of cancer. In general, and it varies on the type of cancer and the overall prognosis from the cancer, but in general, for patients who may be eligible, there's often a specific waiting period where they have to demonstrate freedom from cancer before they're eligible to potentially receive a transplant kidney. And so it does involve a number of factors from the screening perspective, as well as a general baseline health perspective to see if someone may be appropriate to receive a kidney transplant. But again, this would be the reason why we have the ability to collaborate on a multidisciplinary team to make sure that if it's appropriate, then we can kind of have those discussions.
Thank you. If a person has been diagnosed with muscle invasive urothelial carcinoma of the bladder and the tumor is blocking the ureter, should a stent or nephrostomy be considered in an effort to lower the creatinine clearance to allow for cisplatin versus carboplatin?
Absolutely. So it's actually not too uncommon that we may pursue that route because we do want to maximize the ability of a patient to receive what may be life-prolonging therapies. And so if we think that there could be some potential for kidney compromise due to obstruction from a tumor, then placing either the nephrostomy or even a stent would potentially be a way that we can allow them to receive cisplatin as opposed to having to receive carboplatin or another agent. And so that's absolutely something that we do.
Well, Nirmish, I see we've gone beyond the top of the hour. I wanted to thank you very much for sharing your wisdom with us today. I wanted to thank all of you for joining us on the Zoom meeting today. And again, hopefully we'll be able to see all of you in a hybrid kind of Zoom in-person format very soon. Goodbye, everyone. Have a good week and continue to stay safe.
Thank you, everyone. I appreciate it.